In this lesson, neuromuscular weakness, what I want to do is draw together some of the topics that we've already covered and see how they can predict or at least relate to the disorders we're going to discuss. You'll see that I don't have a lot of treatment listed in this section. Management is more about step 2. I'll allude to it, I'll mention it. But what I want you to be paying attention to for this lesson, for this phase of your learning, is the mechanism behind it. First, let's start off with axons. We learned that axons travel a long distance. And because we are not giant squids with huge axons, what we've opted for is using myelin. Myelin is the insulation that prevents the degradation of electric signal through the axon, which is effectively a cable. In this setup, we also have repeater stations known as nodes of Ranvier, where there's a high density of sodium channels. These nodes occur at regular intervals. The problem is, though, that they occur at regular intervals whether or not the myelin is there, because the myelin is supposed to be there. And because myelin is so insulating and sodium wouldn't be able to get into the axon underneath the myelin sheath, there are no sodium channels where the myelin is. So as the myelin gets degraded and eventually disappears, the problem is that there isn't any insulation and there isn't any sodium channels to propagate the signal. So when the original signal comes from above, what's supposed to happen is it's supposed to travel down to the node of Ranvier and activate a new action potential. We're generating the signal being carried through the insulation, activating a new action potential at the next node. When there's demyelination, well, now more of the signal is lost, degraded, because insulation isn't there. But it might reach the next node. Great, that action potential, it repeats the signal. But where the myelin isn't, the signal will be degraded, lost to the periphery, and no signal will reach the downstream effect. It will be as if there was no signal to begin with, because the whole point of the original action potential being formed at the top of the board was to get to wherever it was going at the bottom of the board, and if the signal dissipates, so the action potential isn't propagated, it is as if the thing down below never received the message, as if it was never sent in the first place. Secondly, if we go to the structure of the nervous system, we start up top with the brain at the motor cortex. This is the spine, where the motor neuron will start at the cortex, cross, and as a continuous upper motor neuron, descend until it reaches the ventral horn of the lower motor neuron. It synapses on that lower motor neuron, and that lower motor neuron goes off to innervate the skeletal muscle. At the level of the spinal cord, the sensory nerve fibers come in from the back, and the motor fibers go off from the front. But they eventually combine into a peripheral nerve. And so if you get demyelination of a peripheral nerve, what you're going to see is exposed motor fibers running away from the spinal cord and exposed sensory fibers heading back to the cord, which means that if you have demyelination of a peripheral nerve, you're likely to get both a dysfunction of motor and sensory. The same thing is true of the first order neuron. If you get demyelination of the cord, chances are it's not going to be just of that one axon. So if you have exposed, especially higher up in the brain where things start to cross, you may have a combination of motor fibers running down and sensory fibers moving up, which means that you're likely to get both motor and sensory issues with demyelination. If you zoom in at the neuromuscular junction, we go back to what we learned during the synapse lesson, where we have a presynaptic terminal with presynaptic voltage-gated calcium channels that let calcium in, that cause calcium to bind to the vesicles, which leads to exocytosis. More vesicles coming down from the top. These vesicles are filled with neurotransmitters, and neurotransmitter release into the synaptic cleft, especially at the level of the skeletal muscle, what we're talking about now in this lesson, weakness. There are those ionotropic, nicotinic skeletal muscle silicone receptors on the postsynaptic side, which is what's supposed to happen is these neurotransmitters, acetylcholine, binds to and activates these receptors. And these receptors were those gated receptors when they were not bound to a ligand. And once they bind to acetylcholine, they open up and let sodium into the cell and potassium out of the cell, thereby locally depolarizing. When many activated together, the summative experience was the skeletal muscle fiber depolarized as well. What we're getting at here is that it takes both calcium influx to cause vesicle effusion, which means that the calcium influx is proportional to the force generated, and you need these voltage-gated calcium channels to open to let calcium in to do that. And the acetylcholine receptors on the postsynaptic side need to depolarize the postsynaptic cell by having many, many, many activated simultaneously in order to get the contraction of the muscle. These were the nicotinic skeletal muscle acetylcholine receptors. But the point again I'm trying to make here is that when there was demyelination, both sensory and motor could be involved. When it's at the end plate, there's no sensory deficit at all. We'll explore how weakness is created with these at the very end. If there is demyelination of the central nervous system, it is as if you are losing a first-order neuron. First-order neurons mean, from the weakness standpoint, you're losing an upper motor neuron, which will cause upper motor neuron symptoms. Hyperreflexia, because the reflex arc is based on a sensory fiber coming in and innervating that lower motor neuron, and it's an inhibitory symbol that prevents the reflex. So losing the inhibitor of the reflex makes the reflex hyperreflexia. that prevents the reflex. So losing the inhibitor of the reflex makes the reflex. In this lesson, if you are losing a first-order neuron, first-order neurons mean, from the weakness standpoint, you're losing an upper motor neuron, which will cause upper motor neuron symptoms. Hyperreflexia, because the reflex arc is based on a sensory fiber coming in and innervating that lower motor neuron, and it's an inhibitory symbol that prevents the reflex. So losing the inhibitor of the reflex makes the reflex higher, hyperreflexia. You'll have upward going Babinski, and along with hyperreflexia, you'll have spastic paralysis. This is obviously the extreme form of upper motor neuron lesion, which we're using this as an opportunity to cross over from neuro. And the sensory loss can be variable. We are not asking you now to do a neuroanatomy course or neuroscience where you have to localize a specific level of the lesion. You're not going to have to do that. What I want to do, though, is use what we have on the board to explore what you see in each of these pathologic conditions. So we're almost done building up the scenario, and we'll knock them down with disease by disease. If you have a lesion of the peripheral nervous system, you're effectively having a second-order neuron, which is a lower motor neuron. The symptoms there are hyporeflexia. You won't have any movement of the Babinski, and you'll have flaccid paralysis. As we discussed, you may also have sensory deficits. Okay, let's use what we know about myelin, demyelination, decay of signal, nodes around VA, structure of the central nervous system and the neuromuscular junction to put it all together. Let's first talk about multiple sclerosis. Multiple sclerosis is an autoimmune disease with antibodies made against myelin. Myelin is the wrapping of the central nervous system, which means that we're going to have disorder of the CNS. If you have disorder of the CNS, we're going to have upper motor neuron lesion symptoms and some sort of variable sensory deficits. The patient that you're looking for is a Caucasian woman, 20 to 40 years old, initial diagnosis. And what you're looking for is very easy to spot in a vignette. She's got neurologic symptoms that are both temporally and regionally separate. The only form of multiple sclerosis you have to concern yourself with is relapsing and remitting. Temporally means 3 weeks ago, she had paralysis of her right hand, but it got better. 3 months ago, she had paralysis of her left foot, but it got better. Now, she's got vision problems. So each one of those sounds like, well, that could be a stroke, focal neurologic deficit, yeah. But it got better on its own. And each time something happens, it's in a different place. Each time it happens, that is separated by time, it's in a different place. That is, there could not be one structural lesion that coordinates that same symptomatology. The right arm and the left leg never come together, and not just anatomically, but neurologically either. So anything that's temporally and regionally separated, especially in a young woman that looks like multiple TIAs, is probably going to be multiple sclerosis. But what the boards like to test you on are things like scanning speech. They sound like they're drunk, but they aren't. Vertigo, because of demyelination of cranial nerve 8. Optic neuritis, blurry vision. The MLF, which I'll explain, and basically any focal neurologic deficit. The MLF is very frustrating, but actually very important to people with MS. The way this works is you've got your left eye and your right eye. To move your left eye to the left, you have to pull on the lateral rectus muscle. And that will turn your left eye to the left. This is the lateral side, the lateral rectus muscle of the left eye. This is the medial, which isn't involved. The lateral rectus muscle of the right eye would pull the other way. So in order to move the eyes together, the medial rectus muscle has to pull in the same direction. That would shift the right eye to the left. Well, the thing that pulls both the lateral rectus of the left and the medial rectus of the right to get them to go to the same direction is one place down here. And the thing that connects to the right eye's medial rectus is the MLF. If you lose the MLF, you lose the tug. The right eye doesn't go, but the left eye does. The left eye crosses midline, right eye stops. That's going to cause blurry vision. That's the deal with the MLF. In the notes are all the really long words they like to use to trip you up. Blurry vision. Eyes don't move together. The diagnosis is difficult at this stage because clinically what you do is get an MRI with contrast. And that's all you need, because the MRI with contrast would show you the bright white plaques. Periventricular plaques, white plaques. The contrast is needed so that the inflammation lights up. You don't get, in clinical practice, a lumbar puncture, but you should be able to interpret it because of its relationship to the pathogenesis. If you get a lumbar puncture, what you're going to see is oligoclonal bands of IgG. Oligoclonal means it's not cancerous, it's not monoclonal. You're going to see lots of lymphocytes that those antibodies have summoned, and you're going to see myelin protein. It's in the CNS, where you put the needle. Antibodies bind to the myelin, lymphocytes come in, start picking it off, so you can have myelin being released around it. And if they give you a picture of an autopsy, that is a gross section, because the myelin is the thick stuff that makes the white stuff. White matter is myelin, the axons. If you have a demyelinating disorder, you have the loss of white matter. This confuses students because on MRI, it's bright white plaques positive. On autopsy section, it's loss of white matter. Not a good way that I have for you to memorize it, except that you have to memorize it. Treatment initially is going to be high-dose steroids, and then chronically medications whose names you don't have to remember. This is not a farm lesson, and that's going to be reserved for step 2 and moving forward. The other demyelinating disorder is Guillain-Barré. Guillain-Barré is an autoimmune disorder with antibodies against Schwann cells. Schwann cells are the myelin of the peripheral nervous system, so you're going to get peripheral nervous system symptoms: hyperreflexia, Novinsky, flaccid paralysis. Also classic, an ascending paralysis following some sort of viral illness. And it will either be a diarrheal episode a couple of weeks ago, an actual flu, or even a vaccination. And ascending paralysis means the distal extremities, tips of the fingers and the toes, get weak. And then that weakness begins to ascend their body, their arms to their trunk. If nothing bad happens, it resolves spontaneously. It is not relapsing remitting. It is not a chronic disorder. It goes away. But if it manages to affect the diaphragm, causing paralysis of that, it could be fatal. So what you do when you make the diagnosis is to get a NIF test. How deep can they breathe? And if they do poorly, intubate them. Because if you give them time, it will go away and they will go back to normal. The diagnosis is made with lumbar puncture. So comparing it to multiple sclerosis, not because you need to know to get a lumbar puncture. What you'll see is lots of protein, very few cells. That's the antibodies. But here you're not actually in the CNS where the lymphocytes are, they're actually in the periphery, but those proteins manage to get back up. You don't need to get an MRI, you don't need to get an EMG, you don't need a nerve conduction velocity test. All right, let's save it for now. CNS and TNS, CNS definitely MRI, lumbar puncture. Peripheral nervous system, you generally don't need to do the MRI, and you generally don't need to do the other test. Peripheral diseases, you can use a nerve conduction velocity test, that's going to show you the problem with the nerve, or you can do an electromyogram, which is going to show you problem with the muscle. I didn't mention that because, again, management is not where you're at. It's supposed to be about pathogenesis, but I'm going to mention these now in myasthenia gravis and Eaton-Lambert. If we go to the end plate, and we begin talking about diseases there, we have myasthenia gravis and Eaton-Lambert. Let's talk about myasthenia first. Myasthenia is an autoimmune disease, not demyelinating, with antibodies against postsynaptic acetylcholine receptors. This causes a non-activating competitive inhibition. Before, there were plenty of acetylcholine receptors, plenty of vesicles, any release resulted in contraction. Well, now you've got these things that are fighting you, blocking the acetylcholine receptors. If there's enough acetylcholine release, it'll outcompete those and the contraction will happen. What happens in most situations, skeletal muscle isn't used all the time. So it just kind of sits there. And the longer it sits there, the more vesicles accumulate, so that when that one contraction is needed, there's a bunch of vesicles that dump right away. But if you keep contracting, it takes time for those acetylcholine vesicles to be reassembled, and you lose the reservoir. So immediately what happens is as the vesicles get fewer and fewer, the acetylcholine neuromuscular junction gets less and less, the antibodies start to win, so that the patient is going to present with a decreased force of contraction with repetition. And that also means the small muscles are affected first. Vision, speech, which means swallowing, and hands, fingers. You look around all the time, your eyes are always moving. If your eyes are always moving, there's no time for those vesicles to reaccumulate, which means you get blurry vision, have trouble talking or swallowing. And the highly coordinated movements, well, they go first. The diagnosis is made by detecting the acetylcholine receptor antibodies, and because it's step 1, I think that the MuSK antibodies might still show up. Not so much clinical use, but they're there. And the EMG is going to show a decrease of force of contraction. The first contraction is the strongest, and then it peters out to nothing. A CT scan of the chest is going to show a thymoma. We talk about the treatment for myasthenia gravis using the stigmines. Pyridostigmine is the medication because it can cross the blood-brain barrier. We discussed this in the CNS section in pharmacology, the Gen Pharm section. And a thymectomy is often curative, the thymoma being the source of the antibodies. If we then compare myasthenia to Eaton-Lambert or Lambert-Eaton, the pathology is yet again an autoimmune disease, not demyelinating, antibodies against presynaptic calcium channels. This is almost always a paraneoplastic syndrome. And it's almost always lung cancer. So you'll see the parallels why I do that. In Lambert-Eaton, the problem is the opposite. The problem is that the calcium channels that let calcium in, diffuse the vesicles, are blocked. There are tons of vesicles ready to go. They just need the signal to be released. And without the calcium, as we learned in the synapse lecture, you can't get any vesicle release, fusion, neurotransmitter release, or activation of the postsynaptic cell. Which means that if you just have one action potential, not all the calcium channels would open, but now they're all blocked, so nothing happens. But the more action potentials you send to the presynaptic terminal, the more calcium channels open, the more they outcompete the calcium channel antibodies, the more calcium comes in, and the greater the strength of contraction. Which means that there is an increased force of contraction with repetition. The exact opposite of myasthenia gravis. And because the muscles that don't get used all the time need time to warm up, you're going to get the large proximal muscles affected first. People are going to have trouble rising out of a chair using their quads, reaching above their head using their deltoids, combing their hair. If you find that, the diagnosis is made with antibodies in the serum, looking for the calcium voltage-gated channel antibodies. If you do an EMG, it's the opposite. You start off with very weak and you get stronger contractions as you go, and a CT scan is going to show you the lung cancer. These are not necessarily true, and treating the cancer is going to treat the Eaton-Lambert. There's no way to actually treat this otherwise. I want you to see how easily these two are compared and therefore how easily they are tested. We spent a little bit of time revisiting the things you already know. Myelin, nodes, demyelination, loss of signal with loss of myelin, vesicles mediated by calcium, postsynaptic receptors, skeletal muscle, it's that nicotinic skeletal muscle acetylcholine receptor. And we brought in a little bit stuff from neuroscience, just enough so that we can compare multiple sclerosis to Guillain-Barré. Multiple sclerosis, autoimmune, myelin, central. Temporally and regionally separated. MRI shows white plaques. Autopsy shows loss of white matter. Treat with steroids acutely, then don't worry about the rest until step 2. Guillain-Barré, autoimmune disease, peripheral nerves, ascending paralysis after a virus. Intubate only if it's affecting the diaphragm. They get better on their own. Myasthenia gravis, autoimmune, antibodies to acetylcholine receptors so that repeated contractions reduce force. EMG and antibodies confirm it. Eaton-Lambert, autoimmune disease against presynaptic calcium channels. The more they use it, the better they do. So the force of contraction increases with repetition, and large muscles are affected first. That's neuromuscular weakness.